Hello, everyone, and welcome to today's live broadcast, Point of Care Testing, Why Knowing Now Matters in the Emergency Department, presented by Dr. Ellis Jacobs. We are excited to bring you this educational web seminar presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars, advancing scientific collaboration and learning. For more information, please go to www.labroots.com. I'm Christina Julik, LabRoots, and I'll be your moderator for today's event. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the green Q&A button located at the lower left of the presentation window and type your question into the box that appears on the screen. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the window, just click on the screen icon located in the lower right. If you have any trouble seeing or hearing the presentation, please click on the support button at the top right of the presentation window, or use the Q&A button to let us know that you're having a problem. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located at the bottom left-hand corner of your webpage and follow the process of obtaining your credits. I would now like to introduce our speaker, Dr. Ellis Jacobs. Dr. Jacobs received his BS degree in chemistry and natural sciences from Muhlenberg College in Allentown, Pennsylvania, and then obtained a PhD in biochemistry from the University of South Carolina. He did postdoctoral training in clinical chemistry and toxicology at the University of North Carolina, Chapel Hill. Dr. Jacobs was a laboratory director at the Mount Sinai Hospital, Bellevue Medical Center, and Henry J. Carter and Kohler Goldwater Specialty Hospitals for over 25 years, and has extensive experience with POCT critical care testing, laboratory consolidation and automation, computerization and automatic result reporting, and planning and performance of clinical trials for various main laboratory and POCT systems. He has over 60 peer-reviewed publications and textbook chapters, and was the principal investigator on several beta site studies for various POCT analytical systems. Dr. Jacobs has been involved in establishing clinical, diagnostic, regulatory, and accreditation standards at the local, national, and international levels. He is a former director of the New York State Laboratory Accreditation Program and is active in the Clinical and Laboratory Standards Institute. He is chair of the CLSI expert panel on point of care testing, and was a member of the development committees for EP18 and EP23. Additionally, Dr. Jacobs is a past member and current observer of the U.S. Technical Advisory Group for ISO Technical Committee 212 on clinical laboratory testing and in vitro diagnostic test systems. Dr. Jacobs was the AACC liaison to the Connectivity Industrial Consortium for POC testing, and was secretary and chair of both ANSET and the Point of Care Testing Division. He was a member of the NACB LMPG on Point of Care Testing Committee and is active in the International Federation of Clinical Chemistry. He is past chair of the Communications and Publications Division, was on several IFCC committees and working groups. Please join me in welcoming Dr. Ellis Jacobs. I will now turn the presentation over to him. Dr. Jacobs?
Thank you for that very kind introduction, Christina. One other point I do want to make, that I am currently the Director of Scientific Affairs for Alair Diagnostics, and I've been working with them for a little over 2 years now in helping them expand the utilization and implementation of point-of-care testing. As you mentioned in my introductions, I've been involved with point-of-care testing for over 30 years. And in that time frame, I've seen point-of-care testing being used and misused in many ways. And that's why the name or the title of my presentation is Knowing Now Matters, because it's only when knowing now matters that point-of-care testing should be used. If knowing now doesn't matter, if immediacy of results do not have a value, then point-of-care testing is not the appropriate tool to use. What I'd like to do today is first go over some emergency department facts and figures, talk about some of the issues associated with provision of clinical services in the emergency department, and then go into three key areas of where knowing now matters. One for chest pain, two for sepsis, and three for infectious diseases. Here are some emergency room statistics from the CDC. In 2011, there were over 136 million visits to the emergency department in the United States. Roughly 2/3 of these patients get seen in less than an hour, which is really pretty good. And we can't forget that one of the big changes in the Affordable Care Act is that hospital reimbursement is now closely tied to patient satisfaction. So longer delays to see a healthcare provider will result in lower satisfaction scores, not as well as taking care of issues associated with healthcare directly. And that's also for long emergency department stays. And we can see that 12% approximately only spent less than an hour in emergency department, where the majority were several hours. Notice in this statistic that 1 out of 4 emergency departments now have an observation or clinical diagnosis unit. Also, 1 out of 3 go in diversion, and that's where the emergency department is full and the ambulances have to go to another hospital. And when that happens, they lose admissions, because we can't forget that a major source of admissions to a hospital is through their emergency department. Roughly 1 in 5 EDs have increased treatment of physical space in the past few years, and another 1 in 5 intend to do so in the next 2 years. So we see that there's a lot of changes and a lot of pressures on the emergency department. More recently, in 2015, it was reported that approximately 3/4 of the emergency department physicians have seen increases in patient visits since January of the year before. Additionally, experts are saying that a national shortage of primary care doctors and a lack of physicians willing to accept Medicare patients is also a contributing factor to increased emergency room usage. And finally, in a ACEP, American College of Emergency Physicians survey, 7 out of 10 respondents said that their emergency departments are not ready for the continuing and potentially significant increases in volume. We know that delay in the emergency department leads to poor outcomes. Time is an association, there is an association between waiting times and short-term mortality and hospital admissions. One study documents that if the ED length of stay is greater than 6 hours, that patient is 71 to 79% more likely to die, depending upon how acutely ill the patient is, of course, compared to the same patient whose ED length of stay is less than 1 hour. There's another study, that shows that there's an association between hospital overcrowding and mortality, and that for every hour that an ED patient waits for attention by a healthcare provider, their risk of death increases by 20%. And finally, a 1 hour increase in overall length of ED stay increases the risk of death by 10%. Long ED stays lead to worse adherence to the ACC/AHA guideline care for NSTEMI patients. This last study is part of a secondary analysis of the CRUSADE registry. There are a number of treatments recommended by ACC/AHA for NSTEMI patients, and those who had a longer, greater than 8-hour stay were less likely to receive the guideline recommended treatments than similar patients who had a shorter stay, less than 4 hours in the emergency department. We know that lab turnaround time can impact emergency department operations. In this theoretical study, investigators created a simulation model to predict emergency department performance measures in an urban ED that had an annual census of approximately 55,000 patient visits. they're able to model the ED operations based on laboratory turnaround time. And on all the axes in the 4 graphs you see here, the x-axis is the simulated turnaround time, whereas the y-axis is the analyte or metric being described. So we have diversion days greater than 90 days, diversion hours per day, average patients seen per day, and ED length of stay. And what we notice in all 4 graphs is that at approximately 40-minute turnaround time, the graph either plateaus off on a decrease, or it seems to be plateauing off on the increase. And so it appears that 40 minutes is really the optimum turnaround time to have the most significant impact upon ED operations. Again, whether it's diversion, average patient seen, length of stay, or diversions hours per day. It's important to note that 40 minutes is probably the best turnaround time that most clinical laboratories can meet using their main laboratory equipment. But that is from the time they receive the sample to the time that they report it. And that's different than the brain-to-brain turnaround time, which is what's being looked at in this theoretical description, and is also what most clinicians think about. They're not worried about the time from when the specimen hits the lab door to they get the result back, but they're worried about the time from either when they've ordered the test or when the sample has actually been drawn to get the result back. So the probability is that that point-of-care testing can turn around the results faster, and that is really the case for point-of-care in the emergency department. Faster turnaround times, when implemented with changes in processes and procedures, can lead to better ED operations, which could lead to better ED outcomes. So with that, let's move on to specific areas, and let's first look at chest pain. According to the 2010 CDC report, in 2008, there were approximately 61.7 million non-injury ED visits, of which 5.5 million, or 9.8%, were people presenting with chest pain. Of those individuals that presented with chest pain, we see that 87% of them received a diagnosis other than acute coronary symptoms. And another study showed that for patients that were 45 years or older, when they were discharged from the ED, non-specific chest pain was the most common symptom. Thus, while we associate heart attack with chest pain in the ED, in fact, is very often not the case. However, since heart attack can be lethal, ED physicians must consider it for all chest pain patients. And we know that chest pain is not a specific diagnostic symptom. Well, again, while we associate chest pain in the ED with heart attack, that chest pain could be coming from the heart and not be a heart attack. Also, it could be coming from the gut, other chest organs, muscle, bone, etc. So there's a variety of reasons why a person could be having chest pain and not having a heart attack. And similarly, NSTEMI, non-ST elevated MIs, are not limited or diagnosed by chest pain. To complicate matters further, chest pain is not the only symptom of a heart attack. In fact, the chest pain could be as mild as chest discomfort or shortness of breath, and other symptoms of NSTEMIs are poor diagnostic tools. Sweating, nausea, lightheadedness, and so forth can be attributed to many causes. So there really is a diagnostic conundrum here. And to complicate matters even further, almost half of the chest pain patients get to the ED within 4 hours of the onset of their symptoms. We've done a very good job of educating the public to take chest pain seriously. Unfortunately, this now makes it even harder for us to determine if a chest pain patient is having a heart attack or not. The biomarkers of cardiac necrosis may not have had a chance to rise to detectable levels. Also, the event may not be severe enough or long enough in duration to to cause the other classical or overt heart attack symptoms like shortness of breath, radiating jaw pain, cold sweats, and etc. The emergency department has to make a rapid decision on where to dispose of that chest pain patient because, as shown earlier, delays leads to bad outcomes. Is the chest pain ischemic in origin? Should the cath lab be activated? Could this be an early MI in which the patient should be held for observation? Is the risk of MI low enough to discharge the patient, or should they be admitted for further evaluation? The conservative approach would be to hold all chest pain patients in the ED until you're 100% sure that it's not a heart attack, or to put them into observation, or to admit them. And that might be the safest way to go, but it's really terribly inefficient. We have to remember that 87% of those patients are not experiencing an acute coronary syndrome. The ED has to make the right decision with a high degree of confidence while being as efficient as possible with their time and resources. And a key piece of information to help make this disposition are the cardiac biomarkers. In 2000, the European Society of Cardiology and the American College of Cardiology redefined myocardial infarction. This new definition of MI shifted the MI troponin cutoff away from the older, relatively high receiver-operated curve cutoffs, ROC cutoffs, to the much lower 99th percentile of normal patients. Equally important, this definition of MI requires that there be a troponin level above the 99th percentile with signs and symptoms of ischemia. We cannot forget that. The definition has been amended and refined since then, and the most recent guidelines in 2002 define myocardial infarction as cardiac cell death or necrosis as indicated by the rise and or fall of cardiac biomarkers, presumably troponin, with at least one reading above the 99th percentile. This must be accompanied by symptoms of ischemia and or a handful of other criteria. And we can see the symptoms. We have symptoms of ischemia, new or presumed significant ST wave, and so forth. The important thing is that we have now decreased the concentration of troponin for this diagnosis significantly. Excuse me. Now, what does this change in cutoff actually mean? It means that a positive troponin is no longer an MI. It means that a positive troponin means cardiac damage, and that cardiac damage could be caused by ischemia, which is a heart attack, but it could also be caused by a myriad of other conditions. And here's just a small list of the non-heart failure conditions that can cause elevations of troponin to detectable levels. And some of these conditions make sense, like cardiac inflammation and aortic dissection, and others are a little bit surprising, like innovation. Further, we now know that endurance athletes, marathon runners, have elevated levels of troponin after a race, and thus a detectable level of troponin no longer equals a heart attack. So how's the best way to use troponin I results? Well, if the troponin levels are in the normal range, in other words, below the 99th percentile, then the chest pain is unlikely to be cardiac in origin. Again, remember that 87% of chest pain patients in the ED will not have an ACS diagnosis. If the assay is still using an AMI cutoff and the troponin levels are above that cutoff, then it's fairly likely that that individual is having a heart attack. And if the troponin results are between the 99th percentile and the AMI cutoff, the guidelines recommend the use of serial draws to help differentiate between cardiac damage that is caused by an acute event and a chronic cardiac condition. If the patient is having a heart attack, then the troponin level should rise over a few hours, and if it's a chronic cardiac condition, then the troponin levels are likely to stay stable. Unfortunately, clinical trials for modern troponin assays do not lend themselves to the establishment of the ROC cutoff based on the WHO criteria. The EDs must routinely run serial draws to establish temporal changes in cardiac biomarkers, and the guidelines and literature do not yet give the time intervals and the delta troponin criteria for these, yet they're working on that. And as we go to more and more sensitive troponin eyes, we see studies coming out of Europe and elsewhere that are talking about 1 to 3 hour rule out criteria because of the greater sensitivity of the troponin assay that they are using. But these have not been well defined, and there are no assays of that type available in the US at this time. The American College of Emergency Physicians guidelines for NSTEMI elevated chest pain patients do give some guidance on how to use troponins and to the older biomarkers, myoglobin and CKMB. If the patient has experienced chest pain for greater than 8 hours, a negative CKMB or troponin excludes MI, and that could be troponin I or T. Patients presenting less than 6 to 8 hours, early presenters, can be evaluated using serial draws and multiple markers. And here, negative myoglobin in conjunction with negative CKMB at baseline in 90 minutes, or a negative 2-hour delta CKMB mass in conjunction with a negative 2-hour delta troponin. So it's very important to remember that all assessments of chest pain patients have to be done in conjunction with patient signs and symptoms. All the cardiac biomarkers are clear as an aid in the diagnosis of chest pain patients, not for making the diagnosis. The strategy of the ACEP takes advantage of the fact that after the onset of an MI, the cardiac biomarkers rise quickly. And this graph is a drawing to illustrate this fact. We do have this colored area of the troponin line. We really don't know yet exactly when troponin levels rise with the more analytically sensitive assays, but we do know that troponin levels are detected earlier than 46 hours after an MI onset with the high sensitive troponin assays. Now, here's data from one study that shows what can be achieved with the serial draw protocol. This retrospective study was conducted at 3 Dallas hospitals, which at the time conducted draws at 1, 2, or 3 hour intervals, testing for troponin I, CKMB, and myoglobin using the Alair triage platform. The protocol was to consider a patient positive for MI if, with signs and symptoms consistent of MI, the troponin was greater than 0.4 on any draw, the ROC cutoff. The myoglobin doubled between draws and troponin was detectable on any draw, or the myoglobin doubled and the CKMB increased by 50% between draw, regardless of whether troponin was detectable or not. Knowing that the criteria by which troponin values were being interpreted for MI had changed, the investigators also analyzed their data using only the troponin data at the older ROC-based cutoff of 0.4 and the best approximation of our 99th percentile for the triage troponin assay of 0.05. This slide shows that the sensitivity, specificity, and predictive value of troponin only with serial or single draws using both the 0.4 and the 0.05 thresholds. And we see that by lower, excuse me, we see that by lowering the threshold to 0.5, in both cases, that the sensitivity of the assay increased significantly from the high 60s or from 68 to 97% and from 57 to 80%. So we saw exactly what we were expecting to see, an increase in sensitivity. However, the problem is that this improved sensitivity came at an expense of the positive predictive value. Positive predictive value went from 87% to 37% in the case of single draw, and from 89 to 36% in the case of serial draws. So we now see that we have very high trust in a negative value. Negative predictive value was 99.4 and 99.9%. So if it was negative, you had very good confidence that it was negative. However, it was positive, we weren't sure what that really meant. And one way to compensate for this is to combine the information of troponin with that of CK-MB and myoglobin. And when that was done, and we looked at over 5,000 patients and over 30,000 results that were generated, there was an overall diagnostic accuracy of 99.7%. So now we had the same high negative predictive value as with the troponin alone, but now with the positive predictive value was able to be increased almost up to 93%. So we were able to compensate for the increased sensitivity and non-specificity of the increased troponins by throwing in both CK-MB and myoglobin. However, what does that really mean? Here's another study that showed the operational benefits that can be achieved using a rapid disposition protocol, using the same protocols that were just shown at the Dallas hospitals in the previous couple slides. In this case, this was done in New York City at a major academic hospital, and they developed what they called the RACE, or the Rapid Acute Cardiac Evaluation Pathway. In this hospital, any suspected ACS patient was sent to the telemetry unit for monitoring. And the emergency department's physicians hypothesized that the volume of admissions to their limited pool of telemetry beds was one of the main contributors to a prolonged ED length of stay for patients being evaluated by or for acute coronary syndrome. They further hypothesized that by utilizing the RACE pathway, they would be able to reduce the number of admissions to the telemetry unit and thereby reducing the ED length of stay for those that were being admitted to the telemetry unit, as well as for those being discharged. And this data shows that when they implemented the RACE pathway, that the hospital length of stay for the RACE patients decreased by approximately 26%. By 20%, 26% were discharged directly home, and that was the major cause for that overall hospital length of stay decrease. But we also, it's interesting to note that in the ED length of stay, even the non-RACE patients had a significant decrease in their emergency department length of stay. The RACE patients had some, but it was not did not trigger a statistically significant factor. And the hypothesis there is that by bleeding off those patients via the RACE protocol, with 26% being discharged home and 55% admitted directly to the general floor, that the demand on the telemetry units for all patients being sent there, whether they were being sent there through the RACE protocol or the non-RACE protocol, was less, and therefore they were able to be seen and had care in the telemetry unit better. So even though the protocol was applied to RACE patients, it actually positively impacted all patients in the emergency department. Overall, with this implementation, there was a 20% reduction in hospital length of stay, a 33% reduction in emergency department length of stay, and a 62% decrease in the 30-day mortality of these patients. what happened here. Sorry, something happened with my screen. Okay. Sorry about that. Now, it's very important to understand that simply introducing point-of-care testing for cardiac markers is not really sufficient to improve ED operations. In this study conducted at 4 hospitals, point-of-care troponin testing was used for half the patients, and regular lab-based testing was used for the other half. As expected, we see that the turnaround time for the troponin results with point-of-care testing was much better than that of the lab, from a little under an hour to 15 minutes. And in addition, the percentage of results that were available to the physician that were available in less than 60 minutes went from 53% to almost 100% with point of care, and those that were available to the physician in less than 30 minutes went from 3% to almost 87%. These are very impressive changes in turnaround time and in getting the results back to the physician in a prompt manner. However, they had no significant impact on ED operations. For those patients that were being admitted, the time to disposition decision was only reduced by approximately 8 minutes, and the time to departure was reduced by 9 minutes. And those patients where they were going to be discharged home, the time to disposition was decreased by 20 minutes, but again, the time to actual departure or action upon that was only reduced by 7 minutes. The authors concluded that the impact of the improved turnaround time of point-of-care testing on ED operations has to be considered in all ED operations in order to take advantage of it. If you don't take advantage of it, if you don't change your processes, then just getting the results faster doesn't necessarily help you. And this has been shown in many other studies, not just in the emergency department. So now let's take a second or two or three and talk about emergency room and sepsis and why knowing now matters. Sepsis, as we know, is a very serious medical condition caused by poorly regulated immune response to infection. It's comprised of a complex chain of events involving inflammatory and anti-inflammatory processes, which can result in a variety of presentation symptoms: fever, decreased core temperature, elevated heart rate, altered mental status, abnormal white counts with increased immature forms, hyperlactemia, and increased plasma procalcitonin. In severe cases of sepsis, one or more organ fails, and the worst case scenario is a continuing decline of overall health, including a decrease in blood pressure, weakening of the heart, septic shock, multiple organ system failure, and eventual death. The incidence and mortality of sepsis has been on the rise, primarily due to an aging population, increases of chronic disease, and the spread of antibiotic-resistant organisms, as well as an upsurge in invasive procedures and broader use of immunosuppressive and chemotherapeutic agents. Sepsis remains the leading cause of death in critically ill patients in the United States. Each year, over 750,000 people will develop sepsis, and almost 250,000 will die. This mortality rate eclipses AIDS and breast cancer combined. In 2002, the Society of Critical Care Medicine published their very first Surviving Sepsis Campaign guidelines. And their goal was to elevate clinical awareness of sepsis and improve diagnosis and treatment with the initial goal of reducing septic mortality by approximately 25%. The guidelines have been updated several times, and the most recent ones were published in early 2013. The diagnostic criteria for sepsis requires evaluation of 5 basic physiological areas: general symptomology, inflammatory response, abnormal white counts, CRP or procalcitonin, hemodynamic variables, blood pressure, organ dysfunction, looking at arterial hypoxemia, acute oliguria, Ellis, thrombocytopenia, and tissue perfusion. They look at capillary refill, and they also look at lactate, which happens as part of the metabolic pathway when oxygen is decreased in its concentrations or when there's anaerobic glycolysis taking place. Lactate was identified as a key marker for sepsis because it's produced by the tissues that are lacking oxygen. We also know that sepsis-related mortality is worse when lactates are elevated. In addition to offering or defining the diagnostic criteria for sepsis, the Surviving Sepsis campaign also established guidelines for the treatment and other performance measurements like antimicrobial therapy, infection prevention, and infection source control. The campaign strongly urges the implementation of defined protocols for the treatment of patients suspected of sepsis, especially those with blood pressure that remains high after administration of IV fluids or whose lactates are very high. The 6-hour goal is to normalize the blood pressure, improve urine output, improve oxygenation of the tissue, and thus lead to a normalization of any elevated lactate. Normalizing the lactate or lactate clearance is associated with improved patient outcomes. To be able to make fast decisions regarding patient care, point-of-care measurements of lactate, including serial measurements, may be useful and more expedient than central laboratory testing. Now, there's good evidence that the Surviving Sepsis campaign protocol can work. The mortality improvements of the study here may seem modest, but this data is pooled over 252 sites, and it's difficult to know how well all 252 sites are able to strictly adhere to the protocols. Yet we do see an unadjusted mortality decrease from 37 to 30.8% over a 2-year period. Studies at single sites can compare compliance with diagnosis and treatment bundles with outcomes. And here, this study at the Mayo Clinic shows that as sepsis bundle compliance rose, sepsis-related mortality fell. It went from, as bundle compliance went from 13 to 53%, mortality declined from 30 to 22%. And then finally, in this third study, we see even more impressive results. Mortality of the septic patients that were not managed by Surviving Sepsis diagnosis and treatment protocols was over 60%, while those that were managed by the same Surviving Sepsis bundles, that dropped to 20%. Very, very significant improvement in patient outcome by implementing the Survivors protocols. CMS now requires that hospitals report on several metrics related to their sepsis identification control protocols. It's become that important of an issue. They want to know how quickly and how consistently hospitals are executing important diagnostic and treatments for septic patients. And hospitals that have poor metrics will actually see a decrease in their reimbursement from CMS. A 2010 study in the Journal of Emergency Medicine found that point-of-care testing provided a reliable and feasible way to measure lactate at the bedside. Some studies have suggested that base excess is an accurate marker for the prediction of elevated lactate in the ED. However, some studies also show poor correlation due to the effect of other conditions on base excess. Point-of-care lactate is useful in the diagnosis of sepsis at the bedside and is recommended for institutions where clinical decisions are limited by lack of laboratory infrastructure or reliability. Also, remember that lactate levels rise quickly when the blood sits in the tube for any length of time. And by doing point-of-care lactate, you remove that variable from the situation. The surviving sepsis bundle suggests that serum lactate must be available with rapid turnaround time, within minutes, to effectively treat severely septic patients. An arterial blood gas analyzer located in the clinical laboratory usually accomplishes this. Hospitals should make sure to invest in adequate equipment to meet present standards of care for septic patients. If a central analyzer is not efficient in a particular hospital setting, point-of-care analyzers should be evaluated for being able to provide faster turnaround time. The purpose here was saying, don't forget about creatinine. When we're talking about the need for rapid point-of-care tests, creatinine definitely can fall into that area, especially when we're talking about the need to be able to identify individuals with poor renal function prior to having any type of contrast dye administered to them. Contrast dyes are very renal toxic, and if they don't have good renal function, then you could actually put the person into renal shutdown, and we don't want to do that. So point-of-care creatinine can also play a key role, but again, unless you have done something to identify the fact that you're getting the result faster and have changed your systems and protocols to react to the faster creatinine result, just getting it fast will not necessarily improve your operational efficiencies. And now I'd like to go into the third and final area to talk about, and that is why knowing now matters in infectious diseases in the emergency department. There are many advantages for rapid testing for infectious diseases. We have better directed therapy. We have medical guidelines that outline the specific drug to give for specific pathogens. And without understanding what pathogen the patient actually has, doctors often rely on broad spectrum drug choices rather than specific drug choices. And that can then lead to increased length of stay because of poor treatment of the patient. We understand that antibiotics don't just kill pathogens, they also kill the commensal normal microflora. So we have to be careful about adverse consequences. If we give antibiotics, and we can actually induce C. difficile infection in the patient, because by getting rid of those normal protective flora, we allow the nasty bugs to grow. Reduced lengths of stay in the emergency department, timely application of appropriate infection control procedures, either applying them when necessary and not applying them when they're not necessary. And of course, teachable moments to be able to affect patient care and talk to the patient or the patient's parents at the time about what they're going through. If it's a viral disease, to explain why they are not giving antibiotics to the patient, if it's, and that they should be giving antivirals. So there's many advantages to rapid testing. In this study, these were pediatric patients. There were almost 200 patients seen in the ED, and they were tested with a rapid flu test. The result of the rapid test was shared with half of the physicians to see how the knowledge would affect their behavior. When the flu test was negative, there was no effect on behavior. And that's not surprising, since we really don't know, since we know that the medical professional still does not know what is causing the symptoms. So they still have to do blood counts, cultures, dipsticks, x-rays, may give antibiotics like we were just talking about, may give antivirals, but it's not selective. So having a negative flu result doesn't really change it. However, when they got a positive flu result, we saw that it became an actionable result, and it had a very significant change in behavior and a direct clinical impact. When the doctors were aware of the positive flu test, they ordered fewer tests. They ordered less antibiotics. They ordered more antivirals because they knew what it was, and therefore they were able to be selective in their follow-up protocols and treatments. So again, when it was negative, there was no change. When it was positive, there was a very significant change. And this made a significant advance onto operational metrics. Again, when the flu was positive, we saw that the laboratory radiation charges decreased from $92 down to $15 per patient. And that when the time to discharge went from 49 to 25. So there was a very significant impact on cost and time to discharge, length of stay. And again, longer they stay in the ED, the more negative it is. And again, we saw that when the flu was negative, because they weren't sure whether or not the patient did have flu, but it was a false negative result, or they had something else, that there was no change in the cost of laboratory radiation charges or time to discharge, because they needed to do other things, and they still need to work out that patient's conditions. The problem with most of the rapid flu tests is that their poor sensitivity is due to a difficulty in collecting a good clinical sample. And the best immunological test out there cannot compensate for a poor sample. Molecular methods do address that issue by amplifying it, and that helps make molecular tests sensitive while at the same time maintaining their specificity. The Ellis eye test system provides a sensitive and specific rapid influenza test that facilitates timely action by the clinician. And with this assay, the doctor can be confident in both the positive and negative results. And this slide shows how our rapid molecular test compares to traditionally commercially available PCR methods. And we see that we have a 94.8% positive percent agreement and a 97.7% negative percent agreement with flu A, and with flu B, we have a 98.4 and 99.4 positive and negative percent agreements, respectively. Mathematically, positive and negative percent agreement is the same thing as sensitivity and specificity, but we cannot use the term sensitivity and specificity because that's only when you're applying it against a gold standard or the absolute diagnosis of the disease. PCR is not the gold standard actually for flu right now. The gold standard for flu testing or influenza is culture. So if we were doing this against culture, we would talk about sensitivity and specificity, but because we're doing this against PCR, we talk about positive percent agreement or negative percent agreement. But regardless, this shows that this methodology is very comparable to traditional PCR methodology. And in fact, we say that the Ellis eye has the fastest turnaround time of any of the tests on the market, whether we're talking about the other rapid molecular systems, a little bit better, other molecular systems, conventional PCR, or viral culture. Whether it's for influenza or strep A, the case is the same. And patient satisfaction is often related, again, to the amount of time they spend in the emergency department, and treatment decisions are directly related to the ability to get diagnostic test results in a timely manner. So this system then allows for high performance near the patient and it's also able to be triaged and portable. So it's very advantageous. In 2006, the Center for Disease Control and Prevention published a recommendation that HIV screening be performed on all adolescents and adults in areas where HIV prevalence was greater than 0.1%, effectively stating that all adolescents and adults should be tested for HIV. And they also removed a significant barrier to testing by recommending an opt-out consent. In other words, patients could be screened for HIV unless they request not to be. Previously, HIV screening required the patient's explicit approval to be tested, so that has changed it significantly. There are more recent CDC guidelines since this one, actually June 2014, but this MMWR is still current as the guidance on which populations to be tested. The 2014 guidance just goes into algorithms on how to test, not to whom to test. The policy statement for the American College of Emergency Physicians regarding HIV testing mirrors that of the CDC, recognizing the benefits of early HIV testing and treatment, and recommending screening for all adolescents. One important point here is that the key benefit of emergency department HIV screening, and that is all HIV screening too, for that matter, is the ability for the program to link newly diagnosed patients to resources within the healthcare system to manage and limit further transmission of their disease. So, is rapid testing in the ED feasible? There are several pros to it. High-risk populations use the emergency department as their sole source for medical care. Seroprevalence is relatively high, and it affords an outstanding opportunity. Rapid tests are quick and accurate, and there is a growing experience and body of literature that demonstrates the clinical and cost effectiveness of it. The negatives of it: funding, limited comparison data. Program implementation will vary depending upon resources and site. I used to be the director at Bellevue Hospital Center in New York City, and one of the locations that we did our rapid HIV testing was actually in the men's bathhouses in lower Manhattan. So we would actually, as well as in the emergency department, so we actually went out and tried to apply it to very unusual sites where we knew that we would have the best opportunity to identify or get the those individuals to agree to it. There are some negatives associated with it, but mainly they're perceptions. And as we know, perceptions are not always true, but perceptions are more important than reality, so they do have to be addressed. But there are many benefits of early diagnosis of HIV infection: reduction of high-risk behaviors, reducing the risk of fluid transmission, and allowing individuals with HIV to seek treatment earlier, which will then improve their health, reduce the risk of premature death, and also reduce viral load, which then reduces the risk of fluid transmission. For screening in the ED, you want a rapid, easily implemented HIV test. And simply put, the Allaire-determined combo HIV test detects more early infected patients than any of the other rapid tests available. And we are comparing it to rapid tests now. So, in conclusion, is point-of-care testing in the emergency department cost-effective? Absolutely. There's some very nice review articles covering the value of point-of-care testing for acute coronary syndrome, venothrombolytic events, sepsis, stroke, and these are two quotes with respect to the numerous manual steps to perform in transferring a blood sample to the lab and retrieving the results. The total cost of point-of-care test devices tend not to exceed those of the central analysis. And when used effectively and in appropriate context, point-of-care testing has been shown to reduce delays in treatment initiation in critically ill patients. Elevated cost of point-of-care per analysis seem to be outweighed by the total gain of expedited patient flow in the appropriate setting. The last point alludes to the fact that we can't think of financial silos. Yes, the laboratory budget may go up, but if it increases the or decreases the budget elsewhere by having impact upon ED length of stay, having impact upon ICU recovery time, having impact upon decrease of amount of blood products that are being used on that individual, we have to look at the cost as a whole and not the cost per cost center. And third, and most important, you have to make sure that structural changes, procedural changes have been put into place to take advantage of the rapid result. Again, as we've seen time and time again, that just throwing a result at them faster does not necessarily change how the patient flow is. You need to make sure that they can actually utilize that fast result in a timely manner to have a positive impact on patient care or flow. So in closing, point-of-care testing has been shown to be an effective tool in the emergency department healthcare armory. It does require training, it does require oversight, and it does require planning, but if done appropriately, the benefits can be significant. And that is why we say that knowing now matters in the emergency department with point-of-care testing. Thank you very much.
Dr. Jacobs, thank you for that informative presentation. Now, if you have a question you'd like to ask Dr. Jacobs, please do so now. Just click on the green Q&A button at the lower left of your presentation window, type your question into the box that appears on your screen, and click the send button. Your questions will be answered via email. I would like to once again thank Dr. Ellis Jacobs for his presentation. Dr. Jacobs, do you have any final comments for our audience?
Yes, again, I just want to repeat the same thing that I said at the very beginning of my presentation. Unless knowing now matters, do not employ point-of-care testing. Point-of-care testing is an appropriate tool when used appropriately, and it's not a tool that should be used in all cases. There's a premium that you're paying to be able to provide a result through point-of-care testing for that speed in which you can get the result. And only pay that premium if it's of value to you. So I'm a very strong advocate and proponent of point-of-care testing. I have been for many, many years, for over 30 years now. But I do also know when point-of-care testing is not the appropriate tool. So be judicious, be appropriate, and you'll be successful. Thank you.
Thank you once again, Dr. Ellis Jacobs. Now, before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through February 2017. You will receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now, and we thank you for joining us. We hope to see you again soon. Goodbye.